Day 3, but guess what? It's the last day. See the passion and the energy, how much you're waiting for this weekend to pass. You can go to your hospitals and apply what you learned. I can see it in your eyes, believe me. Each of the small groups. You're just dying to go and apply it. That's fine. Take it easy, shway. Okay. So, a couple of housekeeping issues. One is, we would like to have a group photo. How is that? Is that appealing? Can we do that? Good. Some people would love to even to take selfies. Snappies. Snappies. Is that a word, Dylan? Snappies? Alright, the other thing, I don't know if you have noticed, but those who are in red and purple group, we actually are joining the two groups together, so you've got one common room. When you go to your room, don't be surprised. So we're mixing the two groups just because of shortage of faculty. One of the faculty had requested to be exempted from joining today due to personal issues. So we're joining the two groups, but we're used to this and we can handle it. So you don't have to worry about having a bigger group in the room. We'll manage about the discussion level. As we're starting day 3, we are about to start the first large group presentation, and Dr. Iorio is going to start the day. Alfonso.
Just one extra second, but I realized that one of the slides doesn't show up nicely here, so I'm changing the file. Good morning, everyone, again. I'm quite sure you will be all bored to start the day by listening to me, but it's the last day, so good news. Now, we'll move to clinical decision making. I anticipated you that we would have gone in circle, in spirals, try to rehearse. The Latins were saying repetita iuvant. The more you hear about it, the higher the chance of retaining, and also to show how all the pieces comes together. So my two lectures today will be basically taking pieces here and there among the tutorials and the other lectures to try to pull them together for what is clinical reasoning and application. 3 of the talk I gave this year are brand new compared to the previous edition of this course. I didn't tell you on the first one because I didn't know you enough. I was not confident enough. But this one here and the last are brand new. So please provide feedback as detailed as you want and can. Don't be shy. Anything that doesn't work can be changed for the future. And I really see presentation being smooth and nice after the 3rd, 4th time you give them in courses. So I don't expect this will be perfect. Feel free to help by pointing out anything that doesn't work. You saw on all my presentation the GRADE logo, the Health Information Research Unit logo, and the Clarity logo. Today you'll understand why GRADE and Clarity are there. Clarity is a working group, is more of a think tank hosted by Gordon, PJ Devereaux, myself, John Yu, Deb Cook, Mike Walsh. Is a group that is mostly committed to make presentation of EBM clear to audiences. So you'll see some of the concepts today geared to communication. Those come from the Clarity group. GRADE, you know what GRADE is a method to issue guidelines, and we will focus mostly on decision making and so guidelines. The objective for this lecture are mostly to review the main components of a guideline development process, because guidelines we hope to be able to apply to our clinical decision making in our clinical routine. It's important to understand how those are prepared, how you end in having one recommendation more than another. And in doing so, one of the objective is to frame the basic concept of critical appraisal into one of the steps of guideline developments, which is the evidence profiling. And the bottom line concept is to empower appraisal of a guideline. You would wonder why we need to appraise a guideline. A guideline is already appraised evidence, packaged to be ready for usage. Well, you still need to check if that applies to your patient. You still need to check if the components of judgment in the guideline fit with what is required in your specific decision. Guidelines are not law. It's not something you have to abide to, period. Are recommendations, are suggestions, so you still need to see if they fit or not. You are familiar by now with the pyramid of evidence, studies at the bottom, and then systematic reviews. In this version are called synthesis, and then summaries, the textbook. System would be when evidence will pop up in your electronic medical record or in your decision support system in the hospital, where you, in a future that we hope is not that far, we would not need to go and search for the literature, search the literature for evidence, but find evidence popping up automatically where we put in a diagnosis for a patient or where we put in a treatment for a patient and something says, oh, beware, there is a drug interaction, or beware, there is a better treatment than this one in this situation. We are not there, but these are on top of the pyramid of evidence. Now, this is a bit complicated. There are the synopses in between. So when I joined the HIRO research unit, I started discussing with Brian if there was any way of improving this pyramid. Also, there is something missing here. What is missing in this pyramid? Don't say colors, I know that it's black and white, but what else is missing? Come on. RCT are among studies, any kind of study. Sorry? Case report are studies. Any kind of study design is bottom there. Then you have pre-appraised study, the synopsis, systematic reviews, pre-appraised systematic reviews, textbook. What else is missing here? Guidelines. Right, well, it was not difficult. The talk is about guidelines. So, anyways, good. I'll try to wake you up this morning, so be ready to answer the question. This is the revised version of the pyramid that we will be publishing, hopefully in a few weeks. This is shown for the first time, so Boran 2015 has the privilege of seeing for the first time this version of the pyramid, where you see studies at the bottom, systematic reviews. I was successful in convincing Brian that synopsis and original could stay together, so we shrink down 4 level to 2, studies, systematic reviews, and then you have guidelines that we call the systematic derived recommendation. And then you have the textbook and the system. So systematic reviews get pushed down by guidelines, and I'll try to explain you why. And let's try to start from the bottom. This is a guideline. I picked one that is geographically close to your place, to this place. Over the last 2 years, the GRADE working group, with some of the most outstanding members, Holger Schunemann, Nancy Santesso, Eli Yakel, worked with the Saudi Center for EVHC to come up with a set of 10 guidelines that you can get for free on their website. And some are brand new, some other are adaptation of other guidelines to the Saudi contest. This one is on breast cancer, particularly on screening. And these are the recommendations, some of the recommendations. And of course, is directly the Ministry of Health guideline panel suggesting all conditional recommendation. And then you You can read whatever you want. The first one says screening with mammography in women aged 40 to 49, every 1 to 2 years, low quality evidence. The second one suggests screening in higher age group every 2 years, moderate quality evidence. So you start wondering why low quality every 1 or 2, then when the age goes up every 2 years, but the evidence is stronger. R4, self-breast examination not to be used as a single method of screening. Very low quality of evidence applying to all ages. How you get to transform evidence into graded recommendation? Because this is what we have been trying to do in the previous 2 days. Now, we have to understand the mechanism, and we have to understand how we can judge if, in coming to this conclusion, they use the proper method. And we have to clarify 2 concepts. One is the likelihood of an event, and the other one is the confidence we have in the likelihood of the estimate. These are 2 separate concepts. This is a very famous vignette from the Wall Street Journal that was up shortly after the recession in 2008 and 9, and was sort of pulling legs of economic prediction, saying the setting here is forecast, weather forecast, and to explain the difference between belief and confidence. The prediction is, I figure there's a 40% chance of shower and a 10% chance we know what we are talking about. Which is not a contradiction. The probability of shower is 40%. The confidence I have in this prediction is 10%. In other situation, I might be fully confident it will snow because it's so dark, I know it will snow in 10 minutes. So I'm 90% confident it will certainly snow. But some other time, I don't know, and the best I can guess is 40% chance, and I'm very, very little confident. Now, if you translate this to a medical or clinical setting, it's not that easy to imagine you say your patient, I figure there's a 20% relative reduction in risk with this intervention, and a 10% chance we know what we are talking about. If the patient can walk, he will walk away, saying, okay, it's fine. I look for a doctor who has a better understanding of what we are talking about. Sometimes you can, sometimes you can't. This is what is needed to go from evidence to recommendation. The strength of a recommendation reflects the extent to which we can, across the range of patients for whom the recommendations are intended, be confident about the positive and negative effect, and about their balance. You know there are many ways of issuing recommendation, NICE, SIGN, the ACP system, and the Oxford scoring system, grade A, B, C, level 1, 2, 3. When you move from one to the other, it's always confusing. Grade suggests to use strong or weak. Everyone understands what strong and weak means. Weak is called conditional as an alternative, because weak sound, if it's weak, I won't do it. Well, if you only have weak, you can consider doing it, but if you really are a bold person and you don't like the term weak, why don't you think of weak in terms of conditional? Doesn't change, but if that makes you feel better, say conditional. And then, of course, the recommendation can be for or against. You can recommend for treatment or against treatment. What's the implication of a conditional or weak recommendation? Let's start from the bottom again, for clinicians, for us in the room. If the recommendation is conditional or weak, you have to be ready to help your patient to make a decision that is consistent with their own values, with their own preferences. And you may expect not every patient doing the same. One of the criteria that lead to a weak or conditional recommendation is the clinical experience that not every patient accepts treatment. Not because they are lazy, crazy, or they wake up that morning in a bad mood, but just because it's not a clear-cut balance. That's for clinician. We could look at what means a conditional or weak recommendation for policy making or for patient. Leave alone policy making for now. For patient means that for a conditional, the majority of people, of patient, would likely do what is recommended, but many would not. If you think instead of a strong recommendation, for clinician, you are on an easier setting. Most of your patients will receive your recommendation and be happy to do it. And so you may expect less discussion when the recommendation is strong. Still, you have to see if it applies. Now, let's move into the process from evidence to recommendation. I'll help you just by saying that it's a two-step process. What you imagine can be the two steps. What's the first step? We want to give recommendation on breast cancer screening. Where do we start? Proposals. Research. Search the literature. Okay. What if I call searching the literature as looking for the evidence? That's fine. We only search or we review the evidence? Review. Okay, so let's assume that the first step is appraise a body of evidence. We look for the evidence and we make our judgment on the evidence. And what's the second step? Sorry? Conclusion from that evidence. Apply. Well, apply is after. We are now writing up the guidelines. Someone else or ourselves later on will apply. But before applying, we have reviewed the evidence. Is that enough? Sorry? Give assign a strength. Okay. What can you see in between? What you need on top of the evidence to come up with a strength or weakness of a recommendation? Cost effectiveness, for example? Sorry? Clinical judgment? One more. Don't be shy, I can't hear from you. Applicability, yes. Okay, well, you are very much on target. You need to incorporate other dimensions. That's the best way to summarize what you have been saying. So, for example, summarizing studies and balanced outcomes, that's appraising the body of evidence. And then you have to incorporate cost, you said, preferences, feasibility, acceptability. Good. So you woke up very nicely set this morning. Good. Now, let's focus now on step one, rating the evidence. It's a critical step. It requires to have a critical appraisal skill. So you are now well set. And of course, this happens in a panel. You need to come to a consensus. And ideally, you want to do that in a transparent way. And that's what GRADE presumes to do better than other methods. What are the determinants of the quality of a body of evidence? Well, we have started knowing that there are RCTs, and usually they are very good. It's one of the first messages that Faisal gave you day one. We know that there are observational studies. Here you see a binocular. You look at evidence, but it's through fog. You may not see properly, so the evidence might be starting at the lower point. So you start from study, you appraise the study design, and then in GRADE you have 5 factors that can lower the quality. There might be limitation in the study design, what we call risk of bias. I added a picture that comes from the Cochrane. You now know what risk of bias is on top of your feet. You don't need to read, you don't need to think, right? Risk of bias. Then inconsistency or heterogeneity. Yesterday you have been working on systematic reviews. You know what a forest plot is. And you know by looking at the forest plot, how to judge if these studies are consistent or inconsistent. We will come back on some aspect of this, but in general, inconsistency is looking at all the studies together and look at heterogeneity or homogeneity. Indirectness, we have been working with PICO all the time. Now you will see that we have to duplicate PICO and make some comparison, but you have the concept. It's a PICO concept. In precision, you have to decide if the estimate of effect is precise enough or not for your specific needs. And publication bias. Funnel plot, again, systematic review. Yesterday we touched on what a funnel plot is, what we learned by looking at plotting the estimate against its size, standard deviation. So you know everything that is needed. It's just a matter of agreeing how to do this in a reproducible way. There are also factors that can increase quality. So you start with RCT at a high level of quality, observational, intermediate, and then looking at those 5 factors, you can spot defect in studies. Yesterday we spent time in checking what errors can be, where bias can be, and you decrease the quality of the evidence coming from RCT. When you are starting from observational studies, there are factors that can increase quality. This is maybe newer for you. If the effect is very, very large, very, very important, say every treated patient survives, every non-treated patient dies, okay, it's not a randomized study. Would you enroll in that study? Possibly not. You would like to have treatment. So if the effect is very large, this, even if it's an observation, might lead to higher level of quality. If there are defects in the study, it's not blinded, it's not concealed, population is not the best ever that we could have selected, but all the bias we can see, they push against treatment effectiveness or push for treatment effectiveness. So you start saying, okay, what if the study was done better? What the result would be? Would be the same? Would be stronger? Weaker? If all your reasoning says, okay, there is a defect, but even if I had corrected, I would have seen the same, that increases your confidence. And finally, if you see a dose-response gradient, I think was in my first presentation, the mortality for the cardiovascular event rate in influenza, if it increases over time, that's likely to be true. All of this goes into appraising the quality of a body of evidence. And if you look at the evidence profile, this is one of the evidence profile from the Saudi guidelines. So you have up top here the question, should mammography versus non-intervention be used for cancer screening in women 40 to 49? That's the question. Here is the outcome. The outcome is breast cancer mortality. And in the process, you'll define the outcome up front. We don't, at this stage, we don't care of that part of the process. Let's see if I have, you have the pointer. Just because the mouse goes to sleep very, very quickly. Anyways, number of studies, breast cancer mortality is the outcome, and 8 studies. Thank you. So, 8 studies. Risk of bias, serious risk of bias. There is a note, and down here you see high risk of bias, blending and allocation were unclear for 5 out of 8 studies. So you know why they judged serious. Indirectness, serious, and the panel agreed that for some reason the evidence was not applying directly to this specific population. Inconsistency, no problem. Imprecision, no problem. Publication bias, undetected. So the quality was rated low because they had serious problem here. And then you see numbers. You start to see for mammography, you have 448 diagnoses out of 150,000 screened, control 625 and so on. The absolute effect in 1 per million is reported there. and here the outcome is defined as critical. And down for each question, for each outcome. If you know a bit of critical appraisal, through this table, you can quickly judge why the recommendation was weak or strong. And it's trying to say, okay, chance of rain is 40, how high is our confidence that we know what we are talking about? Now, you start from high level of confidence for randomized trial, and then depending what you find, you can, for risk of bias inconsistency, decrease the confidence. So you can go from high to moderate, to low, to very low, depending on how many problems you find. If vice versa, you start from observational study, you start low, you can go lower if you find defect, and that's very common. So very commonly you go lower, because not only it's observational, but it also has problem. But sometimes instead, for the reason I showed before, you go high. You want to know though. You don't want to believe blindly that something based on an observational trial has a strong level of evidence and has a high level of evidence and leads to a strong recommendation. And in an evidence profile, this can be judged. Just a note, when you are judging about prognosis, observational start high, because the best design to assess prognosis is not the randomized control trial, but is an observational trial. But this is the general framework for treatment. Of course, you can go to different levels. And again, this is another table from the same guideline. In this case, the question is, does screening help in this age band? If you look at the last line, false positive result. We will discuss of diagnosis today, and it's not only a matter of precision, sensitivity, specificity, likelihood ratio. When you apply the diagnostic evidence in guidelines, you are also worried of what happened to the false positive. They don't have the disease, they get treated, or they get to have a hell of a life because they think they have cancer and they don't have it. So that's not in the diagnostic study. You need to have other evidence that tells you what happened to the false positive. Observational studies, 2 studies, no risk of bias, no indirectness, no inconsistency, no imprecision, no publication bias. Start low and remain low because there's nothing to raise, but still you can assess how common they are, and this is an important information to have. You have to tell the women you recommend to do screening that there is this chance of having false positive result. Of course, how you judge risk of bias? Well, you know, and if you are starting to build your guideline on a systematic review, you may use the risk of bias assessment that was provided with the systematic review. How you judge imprecision and inconsistency? We have been discussing this in several groups, and I got a question, and I asked my colleague tutoring the other groups, and there was a request from many of you to try to give rules about how to judge precision and inconsistency. So I do my best. I added a few slides. Hope that won't make me go longer. For inconsistency, you look at 3 things. One is, are the effect sites all over the place? If they are all over the place, but it's sort of homogeneous, well, there is variability, but there is nothing weird. If instead you have a couple of studies up here and all the others are here, well, that's inconsistent. Why they are not randomly all over the place, but they are mostly here and 2 are there? There might be some reason why those 2 studies that are not there, I'm imagining 2 studies here, why those are different. And you have to investigate the reason for that inconsistency. So you look at how spread they are. You look at how much the confidence interval overlap. If most of the confidence interval overlap, means that one study could actually be giving the result of the other. So you are confident that when there is overlap, there is not a lot of heterogeneity. You can also look at I-square, these statistics here. I-square indicates is not a perfect statistic. It gets wrong many times, but in general, when it's 0, means that the studies are all sampling the same population. When it's 100, means these studies, they are completely different from each other. There's something that makes more difference than you would expect. So I square of 0, you are happy, there is no heterogeneity. I don't know if absence of heterogeneity makes you very happy, but you should be happy. And 100% of I square, you should be sad, because there's a lot of heterogeneity, which means you have to investigate why studies are different, and that might take weeks. So you might need to cancel your vacation when I square is 100. So 3 criteria: dispersion, overlapping confidence interval, and I square. As to precision, let's do an exercise. I will ask you 3 questions. Which one is significant? I will show you studies there. Be ready to yell. I want to hear your answer, right? So, which one is significant? Which one is most precise? And which one is your choice for your patient? On this side of the identity line, treatment is better. On this side, treatment is worse. Identity line. So let's start. This study here and this study here. Which one is significant? The red one. Good. This was a nice start. Yell a bit more. Which one is most precise? Red one. Why is most precise? Okay. And what's your choice? Red one. Well, that's easy. It's the only significant, it's the most precise. You pick it. Good. Let's try another combination. Red one, blue one. Which one is significant? Both. Both are significant. Which one is most precise? Blue one. And which one you pick? Why you pick the one that is less precise? Yeah, because it's on the right side. Unless you want to kill your patient, you pick that one. Yeah, good. Let's insist. This one, which one is significant? Which one is most precise? The blue one. And which one you pick? The blue? Everyone picks the blue? Is more precise and significant, right? Everyone pick the blue? No. Okay, well, start having doubt. If I was a patient and you were picking the blue, I would look for someone picking the red. Why? It's more relevant. Even if I imagine that this is the truth, it's still better than any chance of the blue. So precision is not the only thing you value. Of course you value significance. You have been very quickly in deciding that when the blue was here was not good. But even if the blue moves here, the red is still better. It's less precise, but even the lower end of the interval is better than the blue. Don't kill your patient, come on. And you still kill patient because some one of these will not benefit enough to be positively effective. Okay, so is one down for you. Let's continue. This one, and this one. Significant, easy. All. Precise, blue. Your choice. I see you're confused. So someone says red, green, blue. Red. Why red? Well, for the same reason. Because the lower limit is the same for everyone. So in this case, in precision, play in favor for you. Because this might be wrong, but it's not lower than this, and may be much better. So red one. Good. What is this red line here? What is that? At least those in my group, we discussed this. How we call it? Piano? How you call it? Huh? Is the decision threshold. So you are not interested in any benefit. You are only interested in benefits that are higher than this value. Okay? Say it's a 10% reduction, a 50% increase, whatever. You are not interested in anything less than that. You are very critical and exigent physician. No better than that, you don't waste money and time. So this study here and this study here. 3 studies actually. Sorry, I forgot the green one, poor guy. Which one is significant? All of them. Because for significant, we still consider the blue line. Okay? Which one is most precise? The blue one. Which one you pick? Blue. Why you pick the blue? Because it doesn't cross the decision threshold. Very good. Now, this one here and this one here. Which one is significant? The blue one is significant. The red one is not. Which one is most precise? The blue one. And what's your choice? So he wants the blue, someone wants the red. The red one. Why do you want the red? It's not even significant. What I'm looking for? No, I agree with you. I won't pick the blue. What I'm saying is why you want to pick the red. Well, but it crosses the line of your minimum threshold, and it also crosses the line of significance. So that's a not significant study. I'm sorry, no one of these is good. So I admit this was tricky, but in this case you pick none. None of this is good, because this one is significant and precise, but is below your threshold, and this one is non-significant, and it would anyway cross your threshold. So none is good here. All agrees?
Yeah.
Good. Let's try another. Again, the blue one there, the green here, and the red here. Which one is significant? All. Which one is most precise? And which one you pick? Red. And this time you're right. This is very imprecise, but is anyways above your decision threshold. Okay, good. It's a bit clearer about precision, how you use it, and it's not a number, it's not a size, it's how that size compares to significance and decision threshold. You will get these slides so you can do the exercise in journal club or academic updates or whatever, until you get it right. But you were very close, so good job. Publication bias, you saw yesterday, funnel plot, you check mostly if the bottom left corner is empty or not, which would mean negative small studies not published, and so the effect size is pushed to the right. Indirectness, how you judge indirectness? Well, you compare the PICO question of the study with the PICO question of your population. So you compare what they use to select the population in the study and what your population is. And you may have a partial overlap. You may have that the population is different, but intervention, comparator and outcome are the same. Or you may have a complete overlap. It's not necessarily that it's okay or not. Maybe the population is okay, or maybe the intervention is slightly different. You have to judge how much applicability is there. And then all of this goes into filling the table of evidence. We can skip this, for example, how reasoning along those domains gets in there. Very quickly, this is only the beginning. This is what you are learning in this course about a guideline process. Then there is much more, which is putting the evidence in context. Is saying is not only RCT, high level, observational, low level, is considering all the rest. Benefits and harms need to be balanced. Different outcomes need to be balanced. You keep into account patient preferences and values, resource use, and so on. And the balance can also bring in cost, acceptability, And if they are balanced, you will give a strong recommendation. If instead goes more to the desirable, well, you are confirmed that it's strong, or can go in the other direction. And you can have many more pieces of evidence. Some are in the literature, some are generated by the panel. The important thing is to make them transparent. So GRADE use a table like this, where the question, the benefits and harm, their balance, the quality of evidence, resource, equity, acceptability, feasibility, are all addressed one by one. You can't read this, and possibly not even this, but for each of the points, there is a question, there is a judgment for the panel, and there is a justification. And this is written during the guideline process, and is published with the guideline. So you cover all the areas going down the form, and at some point you will end in saying, depending on how the balance was, is not fully mathematical, but is very, very consequential. So depending how many of these were in favor or against, you end in giving a strong or weak recommendation. And all the justification is in the notes field. It might take a while, but if the recommendation sounds good to you, oh, it's fine, you apply it. If you don't understand it and you want to understand and approve or not why the recommendation is issued, you go down this form with your critical appraisal skills and you say, okay, I don't agree on acceptability. In my setting, this is not acceptable, not feasible, the cost is different as compared to Saudi, and then all is reversed, all changes. And you don't need to redo the entire process. You just change that aspect and you get to a different recommendation. Okay, I think I can skip this part, just give you the message. The message is that as soon as evidence-based medicine got to be involved in guideline, we quickly realized that there are situations where even if the evidence is low, you issue a strong recommendation. This is a very tricky area. You want to be careful. There is a lot of chance of conflict of interest effect in this area, but there are situations, and are quite complex. It's a matrix of concepts. You have to have a given quality of evidence, and you have to have other aspects, but you may end in giving a strong recommendation in presence of weak evidence. There's a paper now accepted that will come up soon where all of this is described, and I strongly recommend you to have a look at this paper. I might signal you when it's published, but this is a good one to understand where EBM has to say, okay, the rule works in 90% of cases, there are exceptions. And here are some examples, and in the slides that you will see, for example, two of these where there is a life-threatening situation or uncertain benefit, and you go on along the domain and you see, for example, why you recommend oseltamivir for the avian flu independently of having small evidence. And that was recommended by the WHO. Or instead, uncertain benefit high harm, you follow all the process and you end in recommending again azathioprine and prednisone for idiopathic pulmonary fibrosis because of some evidence of effect, but certainty of a high chance of harming patient. It's not important to focus on the example. The concept is sometimes you need to go beyond pure evidence appraisal. Take home messages from this talk. I think this was on another of my conclusions. Most RCTs tell us about drugs, not about their best clinical practice use in terms of which patient will benefit most. Evidence is not enough. And I'm afraid, I'm sorry, that for some reason when I formatted the slide, I used these are the consequences, the take-home messages, apologies for this, these are the take-home messages of yesterday's talk. I misplaced them. The message for today were completely different from these, and were that evidence appraisal is enough, but is the first step. It leads you to the evidence profile. It's important for you to know the dynamic, to know the steps, but that's not enough, because you have to add all the other components to come to the recommendation. And the second take-home message is that you have to revise your pyramid of evidence, and you have to place guideline in between there, because they build on systematic reviews. They don't add anything in terms of evidence, but they add all the other levels. And so they sit on top. Apologies for these two, I will fix them before giving you the slides, was to make the figures visible. With this, I thank you. Or if not, you can take off your, stretch your legs, just change it.
Yeah, be casual. That was great, thanks. Okay, so just while we're fixing computer, just want to notify you that today might be a very educational day, because we're going to learn about something that you probably may not come across during your training programs. The two themes are clinical guidelines and diagnostic studies. Dr. Joseph Lumnick is going to talk to us today about diagnostic studies, and Dr. Iorio had just covered guidelines. I don't think you would ever attend a better lecture like the one that just passed or the one that's just coming. So I'm standing actually between two great presenters and presentations. So take advantage of that, have that applied in your small groups. And I just want to also remind you about the evaluation. So if you we're vigilant about the evaluation, so if you can just complete the evaluations. You've got evaluations on the tables, so if you would like to have them, if you don't have them, you can just steal some from your neighbor table or other tables, or you can just allow us and or notify us and we'll bring you more. Okay, stage is yours.
Yeah, what he said was on the pajama. All right, so welcome to this third day of the workshop. And so we're going to switch gears a little bit and talk about a different type of topic. We've been talking a lot about critical appraisal of randomized trials and other study designs. In the past years, we had done a session on just interpretation of diagnostic tests. And we've decided to shift gears a little bit and give you some tools of how to critically appraise diagnostic test validation studies. So we'll see how this goes. I'm going to try to pack a lot into this particular lecture, and then we'll follow this with a seminar that has a tutorial that we can put some of this into practice. I'm going to start by talking about really what is a review for you, measuring the validity of a diagnostic test. So what is validity? Validity is how close something is to the truth, to the true value. And so when you talk about a diagnostic test or a screening test, the measures of validity are the sensitivity, specificity, positive and negative predictive value. And I'm sure all of these bring back some level of nightmare for you from medical school, but we'll try to review it and make it clear on how you can use these things. A really important point is, in order to tell how close some test is to the true result, or the truth in the patient, you have to have another test which defines whether someone is diseased or not, and that's called the gold standard. The gold standard defines the truth regarding the presence or absence of disease, and then you test to see how closely the test results conform to the gold standard. One thing to just keep in mind is, you always want to ask, well, how good is this gold standard that we're comparing this new test to? Is it a gold standard, or could it be a wood standard or a silver standard? Okay. So let's use an example here of the exercise stress test, which is commonly used in the setting of anginal symptoms. Okay, so a study tests the exercise stress test against the cardiac catheterization as a gold standard. So here you have the gold standard result, cath positive, cath negative, and the stress test positive and negative. Now in these people, they have the disease, okay, because the gold standards, it says they are diseased, and the stress test is positive. So in this case, this is a true positive result. Now it's really important when you're talking about all this, when you use the word positive, you're not talking about positive for disease. You'll get mixed up. Positive is simply the result of the test. Okay? What did the test say? That's the word positive. Don't say he was positive for disease. If you want to refer to diseased, say they were diseased or not diseased, according to the gold standard. In these people here, cell C, the test is negative, but they really have the disease, so this is a false negative result. And then similarly here, the test is positive, but they don't have the disease, so it's false positive. And here, the test is negative, and they have a true negative because they do not have the disease. Okay? Now, another important point here is, what is, from this table, how would you calculate prevalence of disease? Would it be A over the total, or what is the prevalence of disease here? Yeah, so it's A plus C, meaning everyone who's diseased divided by the total. Okay, and we'll come back to why that's an important number. So let's start with the four basic operating characteristics of a diagnostic test. So when you talk about sensitivity, it is concerned about the left column here. It's not concerned with the right column. So what this says is, of those who are diseased, what percent test positive? So this would be A over A plus C, or 166 over 219, and you come up with a sensitivity of 76%. So do you think that sensitivity is high or low? Actually, it's quite low, okay? Now, we will see later that sometimes it depends whether that's high enough or low enough. If you want to say, is it high enough? Maybe it is, maybe it isn't. If it's low enough, we don't know yet. Okay, and I'll show you how that works. So specificity is concerned with the right column. Okay, and it asks the question of those without the disease, what percent test negative? In this case, 112 or 133, and you have a specificity of 84%. Again, quite low. But it might be high enough. We don't know yet. Now you come to the positive and negative predictive values. And what I like to think of when we talk about this positive predictive value is, how much can I trust this positive test result? Okay, think of it that way. What this says, instead of looking at the columns now, we're going to look at the rows. And the test positive row is everyone who has a positive test. And you have this positive test, and it says, of those who test positive, what percent will have the disease? Now, do you see how that's different from sensitivity? There's a different denominator here. It's the one up on the side, up there. So this is A over A plus B. Now, another way to think of this is, the positive predictive value is the post-test probability of disease given a positive test. Let's break that down a little bit. What do you think? Post-test probability means I have a test result in my hand. Okay? I like to have a piece of paper. So I've got my test result, and so it's post-test, and now it's positive. So now that I have this, what is the probability that this person has the disease? And what you need to realize is, it's not necessarily 100%. Just because the test is positive doesn't mean that 100% of these people have the disease. Okay? So in this case, the positive predictive value is 89%. So that means the probability, even though I have a positive test in my hand, the probability that this person actually has the disease is really only 89%. Okay? Now let's look at the negative predictive value. And in this case, 89, you have to decide what you're going to tell the patient, right? You say, yes, you have the disease, or do you need another test to rule in? Now, how about this? The negative predictive values, how much can I trust the negative test? So now this is looking at the last piece, which is this row. So of those who test negative, what percent will not have the disease? So this is 112 over 165. This negative predictive value is the post-test probability of non-disease given a negative test. So I've got a negative test in my hand. What's the probability that this person does not have the disease? Okay? So in this case, 112 over 165 is 68%. So now, what do you think? Could I tell this person, oh, I'm glad to tell you, this test is negative, you don't have the disease? No, you wouldn't want to do that, because what's the probability that he has the disease? 1 minus the negative predictive value, which is 32%. Now this 1 minus negative predictive value, I think, is a more clinically relevant or easy to understand concept. And in this case, it says, of those who test negative, what's the probability they still have the disease? Okay? And that's the 1 minus the negative predictive value, or in this case, it was 32%. The other part of the 68%. Okay? So this is the 1 minus the negative predictive value is the post-test probability of disease given a negative result. All right? So now we've covered we've covered the basic operating characteristics of the tests. But how do we use these practically? So suppose you want to rule out a disease, okay, and you're interested really in making sure this person does not have the disease, all right? Do you think increasing sensitivity or specificity will have the greatest effect on this negative predictive value? Specificity, okay. It feels that way, doesn't it? Why? Why do you think specificity would have a bigger impact? Because specificity is dealing with those without the disease, right? But it's the other way around, and I'll show you why. There's a relationship between sensitivity and negative predictive value. So what do we want to do? We want to maximize this negative predictive value. We want to trust the negative test. So what do you need to minimize? False positives or false negatives?
False negative.
If you want to trust the negative test, you need to reduce false negatives, right? So look, where are the false negatives here? What's the best way of reducing this number? Increasing sensitivity or specificity? Sensitivity, okay? So C is minimized with a high sensitivity, all right? So this comes to a mnemonic that David Sackett and Peter Tugwell and Gordon Guyatt and the group there at McMaster who started all of this clinical epidemiology idea and evidence-based medicine called SNOUT. Now, what you think of is a test with high sensitivity, when it's negative, capital N, helps to rule out the diagnosis. Doesn't guarantee that it rules out, but it helps to rule out, okay? So, does everybody know what a snout is? It's an animal's nose, okay? So, just to help you learn that, a lot of people don't know that over here. But anyway, the idea here is, if you want to believe a negative test, you must minimize false negatives. To do this, you must have a test with sufficiently high sensitivity. But you'll also see in a minute that often the pretest probability can have a great influence on this as well. Okay? Now, Does specificity have an effect on negative predictive value? Yes, it does. But that effect is not as great as the effect of sensitivity. Okay? Now, what about ruling in? So to rule in, do you need to have a high sensitivity or specificity? Okay, you get the other side of it, right? Specificity. There's a problem with this microphone. I like to use my hands because I'm over here in Kuwait and keep bumping it. Sorry about that. All right, so to believe a positive test, you need to minimize which one? This one, B, right? If you want to believe this positive test here, you want 21 to go down. What's the best way to get 21 down? Is increase specificity. So again, there's another mnemonic here called